Hi, this is Professor Mulcahy again. I'm just going to try and make this as short as possible. You know, I don't always succeed at that, but labor support, a best practices approach. So we'll start with what is labor, just to recap our last video. Uterine contractions, painful and regular, that cause cervical change, whether that change is ripening or dilatation, which is opening. And the change progresses, labor progresses in intensity until delivery of the baby. So let's go ahead and make some progress. First stage, from the onset of true labor to complete dilatation of the cervix. That is broken up into latent phase 0 to 3 and active phase 4 to 7. And then we have the transition phase, which is at the very end of cervical dilation, 8 to 10. This is the toughest phase to get women through. And then we have second stage, which is all about the descent and expulsion of the baby, fully dilated to birth. And third stage immediately follows the birth of the baby until we deliver a placenta. So let's talk about the first stage. Why does it hurt? Well, the first part of it is the contractions. And a uterus that has been contracting for hours can have hypoxia. The muscle is just kind of out of steam. It doesn't get enough oxygen to meet the demands. Or a buildup of lactic acid, just like when you get a Charlie horse or a cramp stitch in your side when you're running. Uterus is a big muscle. If it's working really hard, it can get tired. That's one cause of pain. And then we have distension of the lower uterine segment as the baby descends into the lower part of the uterus. As the uterus contracts, it causes pulling on the ligaments that hold the uterus in place. And then finally, the dilation of the cervix itself will cause pain at the cervix. And then pressure on the sacrum when we have back labor, and that baby's head is the hard part of the baby's head is sort of pressing against mom's sacrum. So that's why it hurts, and that's where it hurts. So you can see in a labor where the baby's OA, you're going to start your pain down here low in the abdomen, and it kind of radiates through the hips and back. In back labor, the primary source of your pain is going to be here. Let me point that out to you. Back labor is really intensely painful, and the pain doesn't always let up in between contractions, just so you know. Second stage, why does that hurt? Well, in the second stage of labor, we are stretching the pelvic floor, distending the vagina, putting pressure on the rectum as the baby moves through that canal. And you can continue to have back pain if the baby's in occiput posterior. We also call that sunny side up. So that's why that hurts. And this is where that hurts. Still in the low abdomen, although most people will start to feel pain more in the perineal and rectal area. You can still have back pain. So is it bad to have pain during labor? Well, not really. I mean, it's not a symptom of illness or injury. You didn't break your leg. You're not dying of cancer. It is self-limiting. Every labor ends one way or another. Nobody stays pregnant forever. And it's intermittent. You should theoretically have these built-in rest breaks, unless your uterus is hyperstimulated or you're having that back labor where you're still having pain in between because the baby's head is still resting on that spot. And then finally, labor pain is a little easier to cope with for some women because it begins with mild discomfort. For some women, it doesn't seem to happen that way. And then it increases in intensity over time. So it is sort of a normal kind of pain. It's not like breaking a leg or being stabbed, and then there's the payoff. You get to take that home with you. But on the other hand, that acute pain can lead to stress. And then there's a release of chemicals called catecholamines. And catecholamines can act on our central nervous system. They increase our blood pressure, pulse, and respiration. A lot of times women respond to the pain in labor with increased muscle tension, which will increase the sensation of pain. The catecholamines can cause a rise in blood glucose and increase any kind of tendency towards hypercoagulability. And then that fear and tension that come with the pain, when a woman realizes like, oh, this just isn't normal, sometimes the response is to become afraid and to tense up. And that leads to an increased awareness and sensation of pain. It can actually make the pain worse. Finally, unrelieved pain leads to a dysfunctional labor. The uterus just doesn't respond well when all those catecholamines are being released. And you start to see that those uterine fibers that work so well in concert will start contracting irregularly, almost like muscle spasms and like a Charlie horse. And then mom gets exhausted and she just can't continue and she can't cope. So, what do you do about it? Well, we provide labor support. So, AWHONN put out a very nice position statement on continuous labor support. And the evidence shows that we end up with shorter labors. That's a good thing. Decreased use of analgesia, anesthesia. And that's, reduces the side effects and risk of adverse effects to mom. Decreased operative vaginal deliveries. And that was sort of one of the biggest effect sizes in these studies, is that you had fewer forceps and vacuums. And then, of course, when they fail, or if mom just can't cope or her labor becomes too dysfunctional, she's at risk for a C-section. So that's a really important thing. Labor support also decreases the need for augmentation because the uterus will contract more effectively. Remember the 4 Ps, psyche was one of them. And if we support mom, she'll have a more efficient response to oxytocin. We won't need to give her as much. We see increased 5-minute APGARs. That's pretty exciting. Better maternal-child attachment behaviors at birth because mom's not so tired and so emotionally drained. And then we have increased likelihood and duration of breastfeeding. A mom who coped well with labor is more likely to assume that maternal role a little bit earlier and be a little more active in the care of the baby right away, and increased satisfaction with the birth experience. And that's almost like a duh factor. Like, of course, she's happier when we're giving her support. So how do you do it? Well, we have emotional support. And sometimes it's just, you can do this. It's hard, but you're doing well. And giving mom praise for, you're really working hard with these contractions, but I like the way you're relaxing in between. You're doing the best you can for your baby right now. Supporting mom's choices and preferences, and that's important. Some moms indicate that they want unmedicated birth, and it's important to support that. Some moms say, I want the epidural as soon as I can have it, and it's okay to support that as long as there's nothing contraindicating it. Same thing if they say, I want to use nitrous, I want to use the jacuzzi, I want to use walking, as long as there's no reason not to, honor what mom wants. Sustaining physical presence, sometimes it's enough just to be in the room and to let people know if you are leaving the room, say you have 2 actively laboring patients, I am right here at the desk. I'm a call bell away, and checking on them frequently, even if you have to leave the room from time to time. We had one midwife who used to knit in the patient's room. She really didn't do much in the way of physical support, but just her being there. And women who, when they've studied it in other countries, say that the studies have shown that women experience less fear and trauma, even if a total stranger is in the room and does not interact with them, than being left alone. Guided imagery, visualization. If we know these techniques, we can teach them to mom. They're usually pretty quickly transmitted during labor. I mean, we can't teach full-on childbirth course at that point or hypnobirthing or anything really fancy, but we can teach mom to picture herself in a peaceful spot. We can give her guided imagery scenarios or guide her to places on the web where she can find them. Most people bring a device with them. And then the biggest thing that I think of as my role in labor support many times is to get that support team involved and teach them the techniques that they can use to support mom. If it's a massage or if it's helping them walk or doing the baby dance, getting whoever it is who's in there to support mom to do some of those tasks makes them feel less helpless and also assists mom in a way that uses her support system and the people she trusts. Managing visitors, well, you do the best you can based on the policy you have, but people who are there to be spectators mainly just maybe need some direction and guidance so that side conversations are kept to a minimum and the focus is really on mom. So emotional support can look like this. And you notice that it's really this looks like a home birth or even a birthing center. I do see fetal monitor in the background and equipment. So it's probably a birthing center, but you do notice that her support people are the ones providing those words of encouragement. Um, and next we come to physical support. So these are like the tricks of the trade. A lot of doulas know them. Breathing techniques. So yogic breathing tends to be helpful. That deep, slow breathing, sometimes longer on the exhale. Coaching mom through a few contractions with the breathing. Progressive relaxation exercises where we teach her to sort of tense and relax muscles in turn. A lot of these things are sort of best addressed before they come to labor, but really simple techniques can be used after they're admitted. And you can teach them pretty simply. I usually stay away from the fancy Lamaze breathing and just go with the deep breathing. Now, if mom's congested because she's full of estrogen and her nose is kind of congested, it's okay if she breathes through her mouth. Don't insist on breathe through your nose, breathe in through your nose, out through your mouth. Work with her where she is. Reassuring touch and massage, as long as you have permission to touch. Counter pressure is a great technique for back labor. That baby's head is in a really bad spot on the sacrum, and we press as hard as we can right against the other side of that sacrum. It kind of confuses the nerves a little bit. It works on the gate theory of pain control. Sometimes touching mom's shoulders if she's tensing her shoulders, or touching her hands if she's got her hands clenched into fists, and reminding her relax everything but that big muscle that's working and let the baby press down. Don't fight it. A lot of times that is very, very helpful and can be like a turning point in a labor. Heat or cold. Heat in particular, if there's a back issue or a warm compress, just watch that it's not too hot. Be careful of MacGyvering a hot compress, but a hot shower or a hot tub in particular, if it's not too hot. Test the temperature. You don't want to put mom into a hyperthermic state. You'll start to see bad changes on the fetal monitor anyway. But hydrotherapy can be very, very helpful. Getting her into a tub and saying just float with the contractions, or even into the shower. I would be careful. Do not put the birthing ball into the shower. That's sort of a disaster. You've got an unstable surface and a wet floor, and a mom whose balance could be a little bit off. That's sort of a recipe for disaster. But a shower chair could be appropriate. Something like that to help mom relax and benefit from that warm water. Position changes can be very, very important. If mom is too tired to get up and walking, you can turn her from side to side. There are positions, hands and knees tends to help, especially with back labor. Getting mom up and walking and teaching her when the contraction comes, sway from side to side and rock, almost like you're dancing. You can put mom in a rocking chair. You can put her on hands and knees, or even elevate the bed all the way up and have her lean on the bed as she's standing. We can use squatting sometimes if that feels more comfortable. And then movement. I mentioned the rocking chair, and there's also the birthing ball. Now, mom has an epidural and we want to support labor progress. We can use what's called a peanut ball in between her knees to open up the pelvis. And that's sort of something I can demonstrate in class. So labor support can look like this. Mom in the jacuzzi. She looks really, really content and comfortable. And I can't tell you how many women I put them in the tub, and all of a sudden it's like you just feel the difference. All of her muscles relax. She still experiences pain, but she copes so much better. So if you can get her into the tub, that really, really helps. I'm fortunate where I work. I have wireless telemetry, electronic fetal monitoring that is also waterproof. So we can even monitor the baby in the tub. Or it can look like that. That's called a hip squeeze. And that's a really cool thing to do, especially if mom's pain is radiating from that front all the way across the hips and into the back. Squeeze those hips together and put that nice counter pressure on. Or, here's another support person. Put mom on the ball and have somebody, really attend to her needs. If it can be you, that's great. If it can't, you really need to get her support people involved. So deep breathing As I mentioned, I don't tend to go with pattern breathing as much, and most people don't. It's sort of fallen by the wayside. It was very popular in the 70s, not so much today. But instructing the patient, take in a slow, deep breath and let it out while relaxing your whole body. Make sure the breathing is slow. A lot of times women start to hyperventilate. They get this tachypnic breathing going, and you want them to slow down your breathing. Breathe to your baby. Take your breath to the pain. Nice and steady, that's it. If the support person, and this is something you would train the support person to do, although you can do it as well, if you're noticing tension in the shoulders, hands, use that touch relaxation just as a reminder. Relax the shoulders, relax the hands, and people usually do follow that direction well, and it kind of helps. I can remember being in labor myself, and I had a labor nurse that I work with now who told me, don't fight the pain. Let the baby press down. Let the baby come down. Don't fight it. Patients moan a lot in labor or sigh on the exhale, a lot more productive than screaming. That's okay. That vocalization sometimes really helps them cope. Rhythm is another thing. It's not on the slide, but it does help them cope. So some people will tap out a rhythm, or they'll snap fingers. That's a cultural thing. You see that we have a Liberian population and a Haitian Creole population. Sometimes we see the snapping or tongue clucking, but sometimes people really like to keep a rhythm with the contraction. Pattern breathing, I'm just going to mention it because it's something that the textbooks always get into. It's good for a patient who really needs distraction, but it's also exhausting, and people do tend to hyperventilate with it. It's that he, ho. So that last breath is sort of prolonged. It doesn't really seem to do that much, but if it gets you through a few contractions, hey, it was one more trick you had. And you're one step closer to having a baby. So, every contraction does something. Panting or blowing, I'm going to mention this. This is the one technique with breathing, the special technique that really will help you. You have a mom who's in second stage where she's actually not fully dilated. She's 8, 9, 10 centimeters, and you want her to stop pushing. Either because she's not fully dilated and you don't want the cervix to swell, or because when she's pushing, the baby's heart rate goes down. You want her to maybe skip every other contraction. Get her to blow out like she's blowing out birthday candles, or stick her tongue out and pant like a dog. A lot of women will just do anything you tell them in labor, and we forget it the minute we exit the room. But that blowing or panting, breathing out, makes it a lot harder to bear down. Progressive relaxation is tensing the muscles and then letting them go. And once you feel what tension feels like, you learn how to let it go. And then when it happens again, say during a contraction, the shoulders start to rise near her ears, you can just take her shoulders, very gently rest your hand on her shoulders and say, relax your shoulders, and they exhale and let it out. Visualization and imagery, better if mom has had time to practice with them, but you can always refer to YouTube. It's a great resource, and they have lots and lots of guided imagery. So a word about visualization and imagery, you want to make sure whatever it is relaxing to mom. If you pick a beach and she's like, I hate the beach, it's not going to work. So you have to be a little flexible with your scripts there. Okay, so labor support during second stage. There we are. Laboring down, wait until the mother feels an urge to bear down and allow the mother to be in control. Open glottis pushing. It's okay if mom vocalizes and grunts, as long as she's not screaming or blowing out all her air and not focusing on that downward pushing. We want to encourage mom, relax her face, relax everything but that one spot where she needs to be pushing from. Some women seem to push in their faces, and you say, no, not in your face, all in your bottom. Bring it all down to your bottom. We can use, in second stage, warm compresses to the perineum. That relaxes the perineum and helps it stretch. And some providers will do perineal massage with either KY or olive oil. Olive oil seems to be preferred because it lasts a little bit longer and gives better lubrication. We have special, sterile, it's not sterile, but it's special medical grade olive oil for that use where I work. But those things can help with the pain and pressure during second stage. Position changes. If your mom is able to change positions, and even with an epidural, we can do that. We can get her into different positions, say side lying or supported squatting or hands and knees, anything to sort of help use gravity and use open up that pelvic outlet. And finally, during second stage, where, it's, you almost get into like a rhythmic pattern. That's the way. That's it. That's it. Good. Keep going. Keep going. Keep going. Good job. Okay, now rest. So we use words of praise and we tell her when she's pushing correctly. I see the baby coming down. I can see the baby's hair. That all helps. Use of a mirror, people are very divided on this. There are special mirrors on labor and delivery units that allow mom to see what happens when she pushes. And if she can see the baby's head come down as she's pushing, or she can see how far down the baby is, it kind of gives her that incentive not to give up. But a lot of women just can't watch that. And I'm probably one of them. I never even tried it because of that fear of, this giant head coming out of a place that's usually not that large. You can allow mom to touch the baby's head if the baby is crowning. This is how close you are. See how close you are? It's going to be any contraction now. So here's some positions. That's a squatting position. And you can see dad's supporting her. Squatting for American women can be kind of tough if we haven't developed our leg muscles, but it is the natural position for giving birth. The only thing about squatting in second stage is for a first-time mom, sometimes the rate of lacerations is a little higher, but it does help facilitate descent. It does open up the pelvis, and it can help the baby come out a little faster during second stage. A supported squat using a squat bar, you can see here the foot of the bed is dropped. We have this fancy squat bar. It's really not that fancy. And mom can sit on the edge of the bed and kind of use that squatting position to help facilitate descent. A squat bar with a sheet. This is fun when a patient has an epidural, or even if they don't, but they can't really support a squat, or they can't stand up, or they don't have enough energy to do that, or enough strength in their legs. We can put the squat bar up, have them put their feet on the squat bar, give them the sheet to pull on, and that seems to really help women push very effectively. Side lying. Side lying is useful, especially when we have a mom and the fetal heart rates are not terribly reassuring. You can push just as effectively in side lying as you can in like a semi-squat, semi-sitting or something like that. And it does take the weight of the fetus off of that vena cava and sometimes helps them recover. And there's your happy ending. That's why we do it, why we do what we do. And here's some references for you if you want it in APA format. And then those of you who are overachievers might be interested in some of these resources. Lamaze.org, still in existence. The old classes of Lamaze with the pattern breathing are kind of over, but they still promote and facilitate birth. Childbirth Connection has some really cool stuff on it about things that the labor support person can do. They have all kinds of things with like the Rebozo, which is like a sling. You can kind of support the uterus, take the weight off of the pelvis, and kind of line the baby up a little bit better. And then Spinning Babies is worth like a look-see. We all started to get turned on to this year where I work. And it's all about position changes that help the baby come down. Take a look at it if you want to. And then these books, some of them are my absolute favorites. I have a very old edition of this that I'll bring to class, Heart and Hands, A Midwife's Guide to Pregnancy and Birth. All the pictures in mine are from like 1982. As I got it used off Alibris for $3. But it's a great guide to facilitating normal birth. Most of the births that are featured here are home births. And, however you feel about that concept, certainly we can use some of the tips for labor support. Labor Progress Handbook is meant for nurses, and it's got a lot of different things we can do to make labor go better for women. And then this one's great for dads. It's written by the same author of the Labor Progress Handbook. Well, support people, because it might not be a dad. It might be a partner. It might be her mom. But this is also a great book, and I can bring that to class. Laboring Well, I just downloaded to my Kindle. It's great. It's things that a labor nurse wishes moms would know about how to labor well. And then this one is kind of an old classic. It's, in some places it's very humorous. Ina May was a lay midwife who delivered babies out of a school bus back in the 70s, 60s and 70s. And she has a lot to say about birth. Some of it's folk wisdom. She does understand birth really well, but some of the stuff she says is probably not evidence-based practice. And, she uses terms like pee hole instead of urethral meatus, which, you know, it's interesting, a little more accessible. She wrote another book called Spiritual Midwifery, but worth a look-see if you're interested in labor support. All right, that's it for today. Thank you for staying with me. And I guess we're all done.